All right. Good morning, and I see our all friends on the line, and Anu with me, and we are ready to start our case. But more importantly, as you know, that little change in our schedule this time, which has been in the sense that this will be our fifth year of Meet the Master, the case presentation through Boston Scientific and Eternal Heart Care Center. And we always have done case presentation and then 4 or 5 cases discussion and show. So what I suggested is that at least in 3 of the 6 episodes, which will be for this year, that we get a guest person give some lecture on some specific topic. And I'm very happy to say that Ajay Kirtani, who is the director of Cath Lab and various other titles in the Columbia system and CRF, will be the first guest for this purpose. And he, because of his some lab commitment, will start early with him. But I just still wanted to just start saying, if we can go back to the slide quickly, that what our goal is, that today mastering the HD-IVUS precision imaging for complex PCI, and Ajay will teach us also in various aspects. Of course, moderator is Dr. Makle, and then panelist Srinivas, Vishal, and of course Chauhan, and a few others. I may not be a full list here, and this, as I said, supported by. So just very quickly, this is, we will no conflict. This is a case number 25, a 71-year-old, no problem before, has a positive dyspnea on exertion, positive ctFFR in all the vessels, used to take only anti-cholesterol medication, which is Rosuvastatin, and good in terms of risk factors and normal ejection fraction. And we'll show you the angiogram. Patient had the 3-vessel disease with left main. We did the RCA, normal ejection fraction, high syntax score. Patient came out, had a surgical discussion, did not want to have surgery, and we just did the PCI of the right coronary, and now of the left main bifurcation. So just to say, if we get to the OC of 2017, it will be appropriate clearly with the LMCA and multi-vessel disease with high syntax score after the heart team discussion. So with that note, Anu can show what we have, and then just after the angiogram shown, then we'll go back to Dr. Ajay Kirtani to give the lecture on the ultrasound. On the IVUS, navigating the IVUS, while every trial has shown it is very useful, but we also know it's still in America at least 1/3 of cases only are being done using imaging. Anu?
Yeah, so we have the EDP about 14 this morning. If you see here, EF is near normal. This is the right coronary artery that was done last week.
Yeah.
And this is just to show you, without imaging, the good old fluoroscopy way of identifying severe calcium, tram track calcium, using our eyes, both in left main, LAD, circumflex.
Yeah.
So significant disease of the distal circ after the OM1, then you have distal circ, and then you have disease in the LPL, which is a large size vessel. You don't see a lot in this view in the distal left main, but in the cranial view, definitely you see distal left main, and you see the tram track calcium in the prox LAD. And interesting is there is a moderate size diagonal, though in the it is probably involved angiographically, and after that you have a LAD that is non-obstructive angiographically.
Further down. Good. Yeah. So with that note, with a little brief case, Ajay, the field is yours, and welcome to our Meet the Masters, and you are the inaugural lecturer for this imaging with the workflow and optimization criteria. And thank you very much.
Well, thank you so much. I'm honored as always, and it's always good to see good friends, Samin and Anu. I also know that they're very good and they're very fast, so waiting to hear me lecture is going to probably kill them.
No.
I'm sorry about that.
We want to learn.
What I think we can do is just, it's a great case, and hopefully we'll tailor the talk to the case to make it really be, how do you work through this case and what are they going to do? Because I think many people hear IVUS and they think IVUS makes sense, and others don't, and hopefully I can give you the case for why you should do it and how you should do it. So first, just to start off with, I will say, as Samin said, there are still many people who would do this case and say, I don't need to use the IVUS. And they think that there's adequate data, et cetera. And that just falls apart, because this is a historical slide from Gary Mids showing how many studies there are. There's many more, and this is not even included in this slide. So, but this is not about data. This is about how do we take care of patients. And I would also say, if you don't want to do it and you're lazy, if it was your family member who was having it, wouldn't you want to have this person to have adjunctive imaging to guide and optimize it? And I'll show you reasons why that's important. The big question comes up is that imaging is costly, it adds time and effort, but so are bad outcomes. And bad outcomes add time, effort, and cost to the patient as well, and suffering to the patient. So that's really not an excuse. And I think fundamentally what it gets to is that in many cases, people don't know how to do it. They think it's too complicated. The staff, it groans when they call for the machine, and it's just a real big issue that leads to utilization. So one thing that doesn't get talked about a lot is that these images, the blurry images on the left with conventional IVUS, are not really the case anymore. And what you're going to see in the case that they're going to do is images that look like this, where you can really identify arcs of calcium, you can identify the structures. And to me, this having these newer technologies like HD-IVUS, it's like if I went outside without my glasses on, I could see the world, but it just wouldn't be clear. With good imaging, you actually can see things clearer. So how do you do it, and what's the workflow? So I'll show you a schematic. This is a paper we just published. It was supported by Boston, but I applaud them for doing this because it was a really kind of fundamental way of codifying what do you do during the procedure. And I'll show you some examples from cases, and then you're going to see it in the case that they do. The first thing is you just want to know where your landing zones are, what the lesion length and the vessel size is. So the way you do that is you advance the catheter beyond the lesion and do a pullback. That's it. And now with automation and AI, the system actually does a lot of work for you. So again, you take the catheter, you advance it past the lesion, and you do a pullback. And then what you're looking for especially is the size of the vessel and then the length. That's it. I don't measure areas. I don't do any of that stuff. I literally just go distal. I want to know what vessel size it is because that will tell me what balloon size to pick. I want to see, is it nastily calcified? So do I need to do rota or something else like that? And then what the length is. It's very simple, and you just do it like that. So here's an example of a case. Now, this is a super tight left main, and everybody knows, fellows know, yes, we should do imaging for left main disease. I would say in this case, you don't want to put the catheter down first. Even though these catheters are low profile, this is a case where you actually get flow first, and then you do the imaging. In the case that Samin and Anu showed you, there's actually disease in the left main, but it's not so tight that it's going to go down with the catheter. So in that case, I would actually do the imaging catheter first. But I do want to show this case specifically because I've seen people get into this pitfall. They hear a talk like mine. They say, okay, I'm convinced. Kirtanay sounded like he knew what he was talking about. I'm going to do imaging in every case. And then the patient arrests when they put a catheter across something like this. So that's why I show this. So what did I do in this case? I basically went distal to the lesion. You can see where that lesion was. And I did a pullback. And if you do a cine, you can tell exactly where that is. And so under fluoroscopy, you advance distal to the lesion, you do a pullback, and this image on the cross section on the left shows you that there's not a lot of disease there. So that's our reference segment. If there's a ton of disease in the vessel, generally speaking, you want to start in an area that doesn't have a lot of disease. So that's how you do it. You then do the pullback. This is the pullback through that area. And you identify the cross-section where the lesion is the tightest. In this case, it measured out to be 4.1. Clearly, we're going to stent this. This was even after balloon. But what you can also appreciate on the pullback is that there are some calcified areas, but it's not that heavily calcified. I'm going to show you how the AI software helps us in a second. This was an HD system that didn't have the AI, so you kind of have to do it the old-fashioned way. But for the image, for the purposes of demonstration, I think it's a good case. You can then actually cine at the proximal landing zone. Yes, there's a little bit of plaque here. There's wire artifact here, but overall the vessel looks good. And then because I've done a pullback with a motorized pullback, I can measure the distance between those 2 points. I know there are labs where people are lazy and they don't want to do the automated pullback. There's no way to get a length measurement in that situation unless you take a balloon and measure with the balloon. But if you're doing the pullback, you already get the length measurement. How do we size the stent? This is really important, and you're going to see them do this really nicely in their case. They don't size the stent where the plaque is. The reason for that is because there's Glagov remodeling. Whenever you get plaque in a vessel wall, what ends up happening is the vessel accommodates that plaque and grows. So if they size the stent in the area where the plaque was, they're going to get a perforation because they're going to oversize the stent. So what you want to do is you want to go to the distal reference. We call it the distal reference because it's beyond the lesion, and measure your dimension there. That allows you to size the stent appropriately. Now, then basically what you do is you can also, in this case, you can, and you're going to hear a talk on IVUS guided zero contrast PCI. You can cine here, and then you know that between those 2 points is the actual length. In terms of how do we size it, people get confused. They say, well, what do I measure? Do I measure from here to here, here to here? So I'm going to show you. You can measure from the lumen. The problem with measuring from the lumen is it's always going to be smaller than the vessel size itself. You can measure from the midwall, and you can measure from the media. The problem with the media is it's always going to be too big because you don't want to stretch your stent fully to the media. So generally speaking, the best way to do it is to either go media to media and discount, or mid-wall a little bit, and that's the actual measurement. You're going to see that exactly how they do that. What I do is I look at the vessel size, I kind of measure from here to here, and I go down 0.5, and that's going to be the size of my stent. So then what happens in this case, basically this is stent placed, it's then optimized, and then go from there. And so how do you optimize it? Again, from this article that we wrote, you basically want to make sure that there's no edge dissection, and with HD-IVUS, you can see it much easier than with conventional IVUS. You want to make sure that the stent is not floating in the vessel, although frankly, if it's expanded well, the malapposition is generally tolerated pretty well. And then the key is expansion. And how do we measure expansion? Well, basically, you're looking at the distal reference, and you can come up with an area in that vessel there. And you look at the smallest area within the stent and just compare the two. If they're the same, you're good. If the area within the stent is only 70% of what it is beyond the stent, you know the stent needs to be expanded more. And we tend to try to aim for 80 to 90% expansion as a whole. And this is the IVUS run post-PCI with a big area in the left main here. So that's the final result angiographically. Everything looked great. You could have done it without IVUS, maybe, but you would get a better result if you did it with IVUS. One more case, and then I'm just going to show you some key points about the case that they're going to do. So here's a case, LAD diffuse diagnoses as well. What's your strategy? I think if you ask people, they would come up with a million different strategies to do this. Some people would say I need 2 stents. Some people would say I do a DCB. Some people would ROTA. Some people wouldn't. How do you figure it out? Well, you image first. And so this is an HD-IVUS run of the LAD. You can pull it back, but if you just do it this way, unless you're like Gary Mintz or the IVUS specialist in the Sinai Cath lab or Akiko or somebody else like that, you have to integrate a lot together. And so what's nice about this current system you're going to see is that there's automated AI that goes into it that helps you solve the problem. So what I saw in that pullback is that it looked like there was a distal lesion. I wasn't sure about the proximal lesion, and there was a bifurcation. But the AI makes it easy. In this longitudinal segment down here, you can easily see that there's a minimal area here that's calculated to be 2.8, and you can correct this and see what it looks like on the actual images themselves. And then when we come back more proximally, you see that that area is actually 6.2. So there's plaque in the proximal LAD. It may or may not need to be treated. Just it depends on what happens with the diag. So the AI really helps you identify areas. The yellow stuff here is with certainty. It can do it right. This blue hashed line is because it's not entirely sure because it doesn't see the structures because there's calcium behind it. So it tells you intelligently, I'm pretty confident in this or I'm not so confident in it, and that's the way you can figure it out. So what I did in this case is I tried ballooning the diag, and the IVUS wouldn't cross into the diagonal, so that should have given me a clue. I know if this were in the Sinai Cath lab, this would have been eroded from the beginning, but you don't always have to do it that way. And I think they'll show you the advantages of that approach. Stents won't go, and ultimately with more ballooning, still the IVUS doesn't cross. So finally I come along to what they would have done, and they would have been done with this case while I was still talking. So I finally did ROTA of this. But the reason I do this is because I want to show you what ends up happening after we do ROTA. First, the IVUS crosses, and second, you'll see reverberations and ultimately fractures in that segment. That is the mechanism of action of all these devices. They try to get a fracture so that you can expand the stent. What does that look like? This is what it looks like. So this is a different patient, circumferential calcium. After doing balloon, ROTA, whatever, you see now there's this disarticulation of the calcium here, which is exactly how the stent will ultimately be able to expand because you basically have fractured it. Now the vessel can stretch. Before it's concrete tube, you can't stretch anything because it's just a tube. You have to break that, and that's what that looks like. I will also show one slide from the shortcut trial. This is a trial that showed that despite the fact that things like RotaShock sounds very interesting, basically a strategy of Rota with a cutting balloon or perhaps even Rota with an NC will give you the same area as if you did something a lot more expensive like RotaShock. So what did we end up doing after that? We ended up doing 2 stents at the bifurcation. And after doing the whole thing, this is what it looked like. Yes, I had to stent far down the diag, but it was a worth thing because we were able to get good runoff and flow. And then you can go back and check your work. There's a clear lesion assessment tool that allows you to quickly get your MSA. In the LAD, it's 8.1. In the diag, it's 3.2, but there's diffuse disease all the way through. And so I'm going to accept that. So last few slides, and then we'll get to the case. First, in the ACC guidelines now, imaging is class 1. The ACC Interventional Council, for any complex lesion, you need to do imaging. And we also recommend in this document that there's no way, the only way you can figure out what you're doing in complex imaging is to do it in simple cases first. Because otherwise it's too complicated and you won't figure it out. And this needs to be done at a national level. For the case that you're going to see, there are going to be a few key elements. Yes, they're going to do imaging, but a few things are going to come up. And one is that even if you have osteal LAD or osteal circ and you think you can nail it, most of the time the plaque extends back into the left main. And so whatever you do, you're going to have to do a left main strategy. And so you're going to see them do that. The second thing is, what is the optimization that you need? It used to be thought the original Korean data was 4, 5, 6, 7. Then we realized that it's probably bigger than that. So 5 at the ostium of the circ, 6, 7, 8. Many people committed that to memory. It actually turns out it's probably even bigger than that. And so the newest data from Korea shows you kind of want to get 5, 7 at the circ, 8, 3 even at the LAD, and almost 12 in the left main to really reduce your rates of restenosis. Now, you have to do this within reason. And when there's calcium, you don't want to go crazy because you can actually, especially in nodular calcium, push the nodule through the wall. But what you'll see is that at a minimum, you want to try to optimize and do a good job. And the reason you need to do it is because of this data from Excel that showed that many times after you do all your work, you can deform your stent. And this happens, 6% of the 7% of the time. If that happens, you have a much greater instance of adverse outcomes. And so what I think you're going to see Anu and Samin expertly do is image, modify the plaque based upon what they see on the imaging. The way they're going to do the imaging is going to be precise. They'll go just beyond the lesions. They'll do pullbacks. They're going to use the lesion assessment tools to help them. They'll then prep the lesion. They'll then probably image again, maybe not, but they often do to demonstrate fracture and good modification. They'll put stents in, and then they'll finally image to make sure everything looks good. And they're going to do it as elegantly as they've been doing for 5 years in these transmissions. So thank you so much for listening, and sorry to keep everybody waiting for the case.
Fantastic, my friend. Ajay, a lot of key important point you highlighted, and I'm very happy that we started with. And you know what, let me ask you one question, practical, which question comes up all the time. OCT is coming up with the various AI algorithm. Do you think the IVUS is coming up with those kind of algorithm, or they are falling behind compared to OCT advances?
No, the current IVUS has it.
Yeah, so I think that's what Anu's point is right. The good news is that whenever you have competition in a space, everybody has to step up their game. And so because OCT had the algorithm, now IVUS has it. That's why the rotoblader, you don't have a pedal under your foot, because CSI came out and then they had to get rid of the pedal. So I think you're going to see automation everywhere. AI is here to stay. I know Anu leads a lot of efforts in AI for sure. So yeah, maybe she has some comments, but we're going to see it everywhere because it can certainly help us.
Beautiful. Okay, so with that note, we are all ready here. Anu, tell us what you have done so far.
So if you see,
Ajay, I know you have your commitment whenever you want to. That will be fine. You want to stay, will be fine. Yeah, whichever way. I know you have
I would love
already
to stay, but I'm going to watch from the side. Take care. Bye.
Good. So if you see the angiogram, I think, yes, I think the great talk by Ajay, and yes, could we have done imaging? I think in this case, we already have shown angiographically there is tram-track calcium, which is severe calcium. So you need some kind of atherectomy first. So the question is, what kind of atherectomy, which he has discussed. So could we have done rotational or vital? Could we have done IVL? But, we are always here to show what probably works the best. So we are going to start with rotational atherectomy, not IVUS first, because of the severe calcium that we have in the angiogram. Then the question always comes, and always it is being asked, how do you select the burst size? So of course, if you had imaging, right? You will go right at the site and get the diameter of the tightest lesion and then make a decision. But this is a good old way. If suppose the image you could not image in a case, and how would you select the burr size? So all depends. It's proximal, severe calcium, and the lesion length is less than 20 millimeter. So in this situation, since it's proximal, large vessel, there's not a lot of calcium in the left main, but you need to definitely debulk in the proximal LAD. We have gone with what is called as a 2O burr. If it was a long lesion and severe diffuse, to avoid any kind of a distal embolization, we would have downsized the burr. You want to say
Yeah,
anything?
beautiful. No, that's a great, and we'll ask our moderator and panelist about the burr sizing. But I also say nowadays, just select one burr, and we are going in now. After checking the speed, I tell them, if you're using a Rota Pro, don't even check the speed. Because I have worked with them, come from the company set at 150, 155. So no need to even check the speed outside with the Rota Pro. In the old Rota, the classical Rota, you'd have to check the speed and set it. But Rota Pro, you do not. 99% will start within 150 and 155 outside. Yeah.
Now the wire selection, right? What would you do? Would you do a wiring directly with the Rota wire in this case? If you see there, right at the level where the diagonal is originating, it is a significant disease. So we did use a Fielder fine cross and exchange it to Rota floppy wire.
Good. Okay, Marle, question?
The question is, in India, by and large, 2 millimeter burr size is not easily available.
I would say 1.75 is good enough. Yes.
Wire. Pull back.
Because usually we go for the 50 to 60% of the vessel diameter.
Yeah, just 0.5. Yeah, just that's it. Under 0.5, and I say the second burr in this day and age is your IVL. Yeah, good. Second burr is not second Rota burr. It's a second burr is your IVL. Unless very rare case where IVL will not go, then you go to second burr. But otherwise, your second burr is your IVL. Step burr, which we use maybe 2%, we do about 70 Rota per month of our 330 cases. But second burr is very, very rare because of second burr is usually the IVL now. Okay, I know the India may be a little different because of the cost. I think you should bring back the burr because you need to ablate the distal left main also. So guide has to come out. Yeah, good. Yes.
So we did our 3 steps already, and we were going to start the burring.
Yeah, 20-second burring. And as you know, Ajay have also presented, if you have very tight lesion, don't go with the imaging because that patient may become unstable. Because you know that what are you going to achieve here by the, and I know many times live cases, everybody is so aggressive with the imaging. Not necessary in every case. Not in the beginning.
How much is RPM drop?
About up to 10,000, between 5 to 10 is allowed, as you know, that if when there is a 10,000 drop of the RPM, it's a empty yellow, and then of course more than 10,000 become complete yellow, and of course more than that will be the red. But up to 5 to 10,000 is okay. But you're right, you should not have a too much drop in RPM because more heat generation. That's the negative part of that.
Yeah. Because it can get stuck if you really try to force it across.
Yeah.
And these burrs are only forward burring, don't have the retrograde.
Yeah. So that is one of the disadvantage of the current Rota. And I know that the Merrill is coming up with another Rota system. And they also had just the distal tip. And I'm telling them, don't bring it. Make on the proximal end also, which we actually Boston Scientific already have seen the design. They still have a trouble with the 1.25. Despite the proximal ablative surface, entire cone is now diamond chips, but they're making some changes because the 1.25, which is the most notorious, getting stuck at many places. So therefore, they're still working, but they already have the design. Once I had to go back again into the animal lab, and once it is, then they apply to the FDA and do like they say you need only 20 to 25 cases, and then it will be available to us. Okay, now this is the picture. Looking very good. Get the wire. No, I think we should use a run-through wire. Yeah, this is the rota wire, and we'll just put
Where's
a
the yellow? I don't need this.
side by huh?
Wire introduce a yellow one.
Yeah, you're right here. Yeah.
Is that?
Okay. So you see that nice 2 bar gave a good lumen. No issues, no extra dissection, or even some dissection happens is the part of it. It's nothing wrong in that. Now question will be here that
you change, do you do the parallel wiring or?
Yeah, parallel always. Yeah, no, we just no need to exchange now, and you go parallel unless there is some gutter has been created. Then we'll go back with the same original fine cross and change it to the our workhorse wire for us is the run through, but otherwise we go parallel wire all the time. And now I think another big question, I know maybe we have to concentrate on that part, is there a circumflex ostial lesion? That's I think the deal maker in this particular case, whether you are going to use 1 stent or 2 stents for the left main. There is clearly we have to put a stent in that LPL. That's a 90% lesion. But only question is, do you do a mini crush? But I think we have IVUS is there to help us out. And
I just needed to make a point. I mean, we used to a bar, but if you had, during the ablation, we did see some subtle EKG changes in lead 1, lead 3, likely because of our distal embolization.
Debris.
Yeah.
Debris, yeah. Which is part, that's okay. Only question is that you need to just know how much debris you can create.
Now you want to go to the circ now?
Yeah. No, but let's do the left main first.
I don't know.
And once left main is done, then you take the rota wire out, and then we put a wire in circ, and then do the IVUS there. So let's take the vote by our panelists that what they feel. Is there an ostial circ disease?
It must have created a nice circumferential cut, particularly the tightest portion.
Yeah. Okay, Siddharth and Nagendra, what do you think? Ostial circ. Again, you cannot see it. You saw the aleocaudal, could not visualize angiographically. Yeah.
Angiography, I feel it is tight, although with the rota cut now, possibly you have inflated enough space to be tight, but I feel we have to do something for this, maybe a dab or something.
Can we show the IVUS?
Okay, start feedback.
Okay.
I do the first feedback, 4 mm/s, high definition IVUS. It's a Plox LED bifurcation. Yeah, 360 calcium in the Plox LED. It's huge size gap in left main and short left main. I stop it. So first I push the ALA button, then we get automatic measurement, but I hide this line. So this is a proximal LED, and this is the level of the diag, and come to the proximal. Yeah.
And these are the cuts?
Yeah. But still 360 calcium, but the MLD is more than 2 because we did a 2 bar. Yeah. But still 360 calcium. I don't see clear fracture still.
On the top, no?
Okay. Needs
then come to the proximal LED. Then this is from the 1 o'clock. This is the circ. So this is the ostial LED.
The circ looks good, right?
From this,
we need to go into the circ to really understand if the ostium is involved. We have to image into the circ ostium, and I think we keep talking about this during our imaging live case. We did that last month, left main, because the way the circ takeoff is, the ostium of the circ always is. Kiski can talk on it a little bit more. We actually have a slide showing that why it's important when you're imaging the circ. The way the circ takes off, the image just at the ostium is not that easy to make any kind of to do any kind of calculations. So going back to that LED at the level of the diag and proximal, 360 degree. Okay, look at the 360 degree calcium. Despite us doing 2 bar, I know OCT is probably a better modality to understand exactly what happens. We may have to do another device. Yeah.
Yeah, Makle, what was your comment? Sorry. Yeah.
Yeah, because although it has created a nice 360 degree cut around with the rotablation, but it looks inadequate for the vessel preparation. So either IVL, we should do it.
Okay. All right.
May I,
Yeah.
yeah, so
Yes,
Dr.
please.
Kelly, we all can see the 360-degree calcium here, but we are not sure about the whether it's ablated or not, whether it can be broken by the balloon or not. So is it a good time to test it with a balloon or directly go with IVL?
The way 360-degree cal, so that's why I'm to date
Yeah,
there
you're
is
saying that
no
OCT is better.
imaging. Oh, no, even with OCT, many times you don't see the depth. Certain times you see, not all the time. There are new OCT catheters that are available, but still not the best. And we have not done any kind of study to really understand the composition of the calcium. Can we understand by imaging, or depending on the depth? We know anything more than 5 millimeters, you definitely need some kind of an extra device to take care of that calcium. But just looking at this with IVUS, and Kiski will add more to it, that like we have discussed right now, we will need another device, which is likely IVL. Now the question is the vessel size, so that when you pick IVL, definitely imaging is required. I know rotational atherectomy, we say don't do it, because now you have to do it right. So the vessel size right here is what, 4.0 almost, LAD?
Yeah, this is just after the kind of aneurysmic part. The vessel size average is almost 5.0 vessel. The lumen is 3.8 lumen just after the dia. So
Yeah,
3.5.
that could be ectatic. No, the question
Yeah.
is 3.5, no 4.0.
So of course, because the 360 calcium artifact, we cannot see the EL
There is a
vessel.
lumen 2.4 only. See that? That's where we want to cut now. A very important point. And you know what? That is why there's so much discussion on imaging, that our imaging work, the CCC live, which Anu started, and every other month we do. So much discussion, so much chat questions, and so this is the case where, how do you know? I think that this is the where we need AI. If AI tells us there are 2 fractures, and now your balloon is going to do a good job, you don't need to worry about anything else. Or then we have to test it by doing a cutting balloon or high pressure balloon. So those are the 2 things. To me, looks like there is a 2 nice fracture. So some people say that if you have clear cut 2 fractures, see that 2 fractures in the calcium, it's okay. It's going to expand further. But I don't think there's any algorithm at present, even by OCT, which can say that you are done with the atherectomy and go with the balloon only and not necessarily IVL.
Sir, reverberations mean anything? Does it tell about the thickness of the calcium as far as HD-IVUS is concerned? Or
No.
it is just a
Let's
polished
allow
surface?
Kiski talk.
Yeah. So the from
Sir.
there's a 2 different mechanism. The rotor is the shape, the surface of the calcium, just make the calcium thinner. But then we need a calcium flexure to modify to an stent expansion. But for this case, IVUS resolution sometimes not clear. So some model that said try the balloon and see the calcium fracture or not. Then we can try the IVL. Yeah.
But
so,
do you see any fracture at this time?
Yeah, Dr. Sharma, yeah, in the 3 o'clock, there is some like gutter, small gutter, but we are not sure it's a native plaque morphology or not. So because we don't have a initial IVUS, we cannot compare. And yeah, this is a kind of IVUS limitation. We cannot see the thickness. So yeah, but at this time we can check the balloon expansion or directly IVL. That's up to the doctor, I think.
Precisely, that was my point. What is the harm in testing it with a non-compliant balloon?
Yeah, or cutting balloon, I mean, rota cut, reasonable. Yeah, because we believe in rota. So let's get a 3.5 Wolverine, and then we'll see. Let's go.
Okay, get us a 3.5.
Yeah. So no, put a wire in the circuit or no?
No. There's no osteal disease. Does not have a.
No, you have to stent in the circ anyway.
Yeah, but let us finish LAD, and when we are ready, we go to circ, do the circ, and come out. You want to leave a wire in the circ?
No. That's good.
What is your opinion?
Yeah.
What is your opinion if I want to use IVL? Because it is still a complete calcification with the reverberations there.
Yeah. Nothing wrong in that. I can tell you, lot of people will do. And this combination strategy, it's probably safer. But at the same time, the whole question comes that once you're done the atherectomy, do you need the IVL? So they actually have a trial going on with the nodule shock, which is in the using the IVL with or without rotational atherectomy. So we'll have answer in about how many cases? 60?
No. Total nodule cases are 40. We just finished 17 cases so far.
And there is the combination that after doing the atherectomy in what is the arm randomization, Kiski?
So if you see the OCT-based calcified nodule, you randomize to the IB LOTA plus IBL versus IBL alone.
Yeah. So that we have. So question, this is a question, like moving field, but I would say that in this case, you have done the knowing, let me phrase it different way. If the IVL cost is like your cutting balloon, cost is same $600-700, same way in India is about 60,000-70,000 rupees, rather than having a 3 lakh. You use in every case, you'll use the IVL. Nothing wrong in IVL in this case right now. Just want to say this point. Nothing wrong, will be no negative of the IVL in this case. Only question will be cost, and that do you really need it because of the cost. That's the key. Even here, the IVL cost is tremendous. So IVL cost here is $4,500.
So it comes to 4.5 lakhs close.
Yeah,
4
that's
lakhs.
it. Yeah.
Go up here.
And this is the Wolverine, and then you can go up to 20 atmosphere and see. If not, then you get the IVL. And looks like it's not opening, then it's a good case for the IVL.
Okay, open.
Yeah, opened up.
No.
No.
I also
No.
thought opened up. No, okay, go. You go 20. He's saying.
Of course, I'm at a long distance here.
No, did not open. You're right. Did not open. Good.
Okay,
Then
down.
get IVL 3.5 or what? Or 4?
Wait, one,
Better
two, three,
picture
four.
in the lab, but here,
Four.
I think my co-panelists will definitely agree that it is not expanded. Do you
No,
agree?
we agree.
Nagendra?
No, we have absolutely did not open, but remember, once again, go back. Remember, cutting balloon is that you have to go 3 times back and forth. Every time will be in the different quadrant. All those COPS trial and all those have shown that you need to go to 2-3 times. Each time about 15-20 second inflation, F for 20 atmosphere. Because you'll cut the plaque in a different quadrant. Now, it may not work. That's a different story, but you have to give enough justification.
Wait.
Now, Sine now. That's it. See that?
Okay.
So
down.
those are the teaching of the cutting balloon,
Give the
Wolverine, and so that your second
IVUS.
inflation should be slightly slower than the first one, because sometimes rapid inflation can cut the blade. I mean the balloon, rupture the balloon, and more importantly, you have to do 3 times back and forth. Come out, go back again. It will be different, and it'll cut in the different quadrant. Use the classical example we just saw here, that it really opened up on the second or third one. Okay, and what's the plan now?
You have to image again.
Achha, okay, imaging being done again. And now, what will tell us? Additional fractures on the
Right now, we will know what the balloon did, and if there is, we know the balloon has done. I mean, angiographically, we know it has.
We are not taking the
look
picture
like,
yet.
so let us just
But your
go
balloon
with the
inflated.
imaging.
You want to still leave the rotor wire there?
I'll leave the rotor wire, and as soon as I do the circ wire, we'll remove the rotor wire.
As you see that it's in this case, we did I would call it a cutting balloon plus. Why? Because the 4th blade of the 3.5 cutting balloon and 5th blade is your rotor wire. So we did a cutting balloon plus. Okay, they're doing imaging again.
Yep.
Okay.
Okay, let's go to the imaging, please.
Okay. I start pullback. This is after a loader plus cutting balloon. I come to the proximal LAD. The D1, yeah, I see the fracture. Definitely there is a calcium fracture and bigger lumen. I will stop it. So I will show you. So this is the level of the die. This is the level of the diag. So come to the proximal part.
Yeah, good. Tell us now. Multiple cuts.
This is exactly the Dr. Ajay Kilchane showed from the 4 o'clock and 11 o'clock. There is a fluke. 2 calcium fracture, and the area is now 5.7. It was less than 4 after the loader, and I see definitely 2 calcium fracture in the proximal LAD. So cutting balloon definitely worked.
Okay, so it seems to be that the cutting balloon did the job, but just to say, randomized way, it's a gut feeling, and the way did this case, but we did the rota cut trial, and the rota cut was rotational atherectomy followed by cutting balloon or high pressure balloon, and we found no difference absolutely no difference in MSA between two techniques. We thought that maybe cutting balloon will give you a bigger lumen, but no. But only thing was that there was a little different in approach there that we selected when we know that patient was randomized into the cutting balloon arm, slightly smaller bar, but not significant. And of course, there was no complication in 60 cases between two centers, ourselves, Mount Sinai and St. Francis. We did 45, they did 15, zero complications. So just to say, what is the status of the rotational atherectomy at this time now? These are the heavily calcified lesions. The rota cut, this paper was published in Euro Intervention. We have zero complication. One case has a non-QMI, but no slow flow, no dissection, no thrombosis, and so. And lumen stent area came out about 6.7, 6.5 in both the groups. Yes.
Dr. Samin, the result what we achieved with the cutting balloon was really excellent. The diabetic areas are definitely changed. Will the OPN be of any use at this stage?
One of them.
Assume.
Yeah, I would say that opium could be, if rather than using a cutting balloon, we could have used opium. No question about that. So, opium has not taken a big market in America just because of the cost. Reason is, if we are using IVL, there is additional reimbursement to the institution. Opium is about $1,200 compared to cutting balloon is $600, and there is no extra reimbursement, so that opium has really not taken off much. I know Victory Trial and others have shown that maybe the high pressure will, those really will work, but definitely has not shown, it has not taken in because of our, I would say, the reimbursement pattern in America.
So economic plays everywhere.
Yeah, that's it, everywhere. Okay, you want to take a picture or IVUS? What do you want to do now?
We did the IVUS, so I think looking okay. Let's go to the circumflex now.
Yeah. Okay, take a picture now so we can see circle lesion a little better.
Okay, I wired it.
EKG looking good. Yeah.
The only question is
2.3 balloon? 3 or 15 balloon?
It's a different vessel
size. This is now the fielder wire into the circ. Here. Yeah. I think 3 will be okay. 3 or 20.
No, to both?
Not to the circ.
No, you have LPL, no. That's not 3.
No, this is the one. There. No, we don't go further. Just before.
You don't understand the LPL?
No, not there. Just there. Let this one alone. Just proximal circ.
Oh.
So there is a moderate lesion there. You want to take one picture with the nitro, give the nitro, and let's take a picture. Now there is a more flow in the anterior, after the opening the left main. Okay. Now we have to decide what we are going to do to the circ. Good.
It's a wrong view.
Yeah,
I never go
there. Further down. Leave further down. Just do the proximal. 3 or 20 high pressure. Take that. No need IVUS in this area, right? Doesn't look that way.
Kiski will say IVUS. I think too many IVUS runs.
Yeah. And actually the other point, the publications wise have been that IVUS really helped to improve the outcomes for people who are less than 5 years in their practice. 5 to 10 years was just borderline, and after 10 years was a minimum like trend only. That's the NCDR data. Ready?
Yeah.
Okay. So this is a 3020 non-compliant balloon. There was some calcium there, so open nicely.
So we have a 28 synergy, right?
Yeah.
So we'll IVUS after.
Good.
No, the question was, hold on. Take a picture. Okay. We may have to IVUS because you were concerned about the ostial circumflex involvement. But I think it looks so good.
Yeah, I think leave it. Agreed. No need for IVUS at this
Only
time.
Only question is 3.5 or 3.0?
No, 3.0. Is the circ magnified 3 or 24 or 28? That's the key.
I have 28 ready.
Yeah, 28. Yeah.
I think 3.5. And then we put one stent in the left main to LED.
Yeah.
That's it.
That's it. Okay, this is the Synergy XD. That's what everyone, they are available now. Megatron and Synergy XD really have enhanced the performance, and particularly at the osteal lesions in large vessel with using a Megatron.
Dr. Sharma, what is the bifurcation strategy here?
Yeah, well, that's the whole question was. It's more and more. Initially, we thought we'll do a mini crush, and then we felt now there is no disease in the osteal circ. Should we just put a provisional stenting? No, to pull back more. So question will be, yeah, ready? I initially thought that we do a, ready? Going up. Yeah, so initially I thought that it will be a good case for mini crush, but more and more looks like that osteal is not involved because they did a LAD, and during that time they saw that osteal circ was very good, and so there was even IVUS was not done. But if really we're now going to do a IVUS, and if really the osteal disease, then it's the best case just finish it with a mini crush. I know India is still the DK crush is very much used, but you know Europe, America, the DK crush numbers are small, not that much. It's more up in India quite a bit. China, of course, where they started. Even Japan is not much DK crush, and of course Europe, they love the culotte, as you know. They, in this kind of case, in Europe they'll do the culotte, but we'll do a mini crush.
Prefer it because now the only osteum, a small part is there. In overlapping a stent there versus putting a dab, which is a better strategy for circumflex here.
Yeah. Okay, you want to say? Yeah, so question is that if ostium, I would say that more than 3.5 or so, osteal circ, leave it, because that always complicate. Most of the data have shown that if you have no disease in the ostium, putting 2 stents is a trouble. I mean, a higher event rate. If you have osteal disease, then definitely putting a 2 stent is the right approach. A lot of people say, well, I just do a drug-coated balloon nowadays, even in the large vessel, in a moderate lesion in the osteal circ. We have not adopted that strategy. But yes, we just, when we did a 120 celebration of CCC live just 2 weeks ago, I invited Colombo here, and he said that he's in these kind of cases, he'll just do the he'll just do the drug-coated balloon for the side branch, even in the large vessel.
Okay, this is a distal
Bring
circ.
it to the main screen, guys.
Okay, start feedback. Yeah, some plaque here in the distal circ.
We knew that. Yeah.
Yeah, now come to the big vessel. Yeah, edge of the stent. Yeah, kind of under. Maybe we can do posterior rotation. Now come to the proximal. Yeah, looks the osteal circ is open. I will stop it.
All right, so we need to hear from our team there, our panelists and moderator, or maybe of the audience, that what would you do now? There looks like osteal circ is okay.
Yes. Now come to the bifurcation.
Yeah, bifurcation is completely fine. Nice lumen.
Yeah, so this is looks like osteal circ. Looks open.
Your post-stent MSA is okay?
So yeah, some part is kind of eccentric shape.
We can dilate with a 3O, right? 3O balloon?
Yeah, a little bit under 5.5. So within the stent, some part is under expansion.
Yeah, you want bigger? 3.5?
3.25.
Okay,
yeah, even
3.25 balloon.
Yeah.
Look like a nodule there?
Yeah, there is an eccentric calcium behind the stent. So that's why eccentric shape. Yeah, there is a calcium. No sure nodule or not, but definitely eccentric calcium behind the stent. That's why eccentric shape. And a point is
small.
Yeah, and the other half is plaque free. So even after the stent, like a super aggressive balloon might injure this healthier part. So we might not super aggressive. So risk of the population.
For the left main to LAD, we have 3, 5, 28 ready, and then we can in the left main we can optimize with the 4O. Kiski, do you agree?
So from the IVUS point of view, the distal reference of the LAD, even the lumen is 3.8 and the vessel is like 5.0. So based on the IVUS, you can put 4 stent from the LAD to left main.
Not 4.0? Doesn't look
like
Yeah.
Hello.
Yes.
Yeah. Now, I know that you have clearly demonstrated the circumflex ostium is good, but that is a post-stenting. I would have been more comfortable to do the IVUS before doing the stent and then decide about it. rather than having the.
You mean
something on the
after
tail.
doing the stent of the left main? That's what you meant, right?
No. See, you did a circumflex stenting.
Yeah.
Mm.
Oh,
So in that I would have preferred to do the IVUS and to rule out the circumflex osteal lesion, because circumflex is a Achilles heel.
yeah.
Down.
No, but I think the bigger issue here is that is the ostium, which looks good,
Yes,
going to
correct.
be jeopardized after doing the crossover stenting. Let me go up here.
Yeah, go.
So that is a bigger
Dr.
issue.
Makhale,
Yeah.
Dr. Makhale, I think this is because they have not touched the cell costume till now. I think
Yeah.
this is a very
Done.
good strategy, because the worst outcomes are with the two-stent strategy. If you can get away with it with provisional stenting, that's perfect. Very good.
Absolutely, yes.
No. My intention was to have the data before we do the stenting. That is what I was saying.
That's where I think you need to understand how you got to incorporate imaging, because a lot you can do on angiography, and this is what I think the discussion was also, that just based on angiography, you see that ostium looks okay. Otherwise, you'll need a run before, a run after.
And you have to worry about that large OM1/ramus.
Yeah. All these
Okay,
things,
let's go
so-
here. Because we still have to deal with that ostial diagonal. Hopefully that remains
Yeah,
okay.
yeah,
Let's
I
take a
think that's
picture
okay.
and then we go to epicranial. Beautiful. We call it SFSG. So far, so good.
Go.
Okay. So let's get a stent size, and so we have figured
No,
out.
he's saying 402. I mean,
Yes.
length 28 is good enough.
Yes.
Right? We never
40.
took a cranial picture. I
Okay.
think all we did was IVUS. Yeah.
Good.
So far, EKG is good. So I think diag should be fine, behaving. Okay, go. Okay. Wow. What? Okay.
Diagonal can give the trouble.
I don't think so. Give me. I mean, there's some dissection extending into the diag. Do you see that in the IVUS?
So at this time,
Angiographically, we see dissection extending into the diag. Do you see that?
this time not clear. We see
Not
calcium
clear?
fracture, but
Okay.
not big dissection.
Okay, 4028.
Okay.
And then get us left main is 45.
Yes, correct.
458. Yeah.
High pressure balloon.
We have the pot balloon available here also, but we are not using that
Hello.
much here. But pot balloon, we are not started using it here because same, everything comes up with a price tag. The usual balloons are $200 and pot balloon is 500. So we thought that maybe we might keep some 4 or 4.5, 8 millimeter, and so that will be a good one. And as you see, our nurse is keeping the patient nicely snoring. You might be hearing the noise of the snoring is not from the doctor, nurses, it's from the patient.
After this, the patient will say, are you sure you did the procedure? Okay, some die. Okay, I'm bringing back.
This is what, a Megatron?
No.
No, this is a 4 regular
Synergy
synergy.
XD.
Yeah. Some die. Okay.
Yeah,
Good.
let's pull back a little more. This could have been actually Megatron also. Could have been Megatron.
I would not have done that. Okay, ready?
Yeah.
Oh, they wanted it.
Good.
Yeah. Okay, go up.
Okay, go up. Now here is the conflict of opinion. The Anu will leave it. I would have wired the diagonal before stenting.
Okay,
Whether alone wiring, you have to go to 16 atmosphere. You didn't expand middle one.
Yeah.
Get a 4.58 balloon. Ready? Okay, good.
Okay, go up. This is why I wanted a 3.5. You see that? Not a 4.
Yeah, no. Anyway, you get a 4.5. Good.
Okay, down.
It opened nicely, but you need a little more push.
No, you can't do 4.5 there. If you need, you
Then
need a 4.0.
Get a
in the LAD.
408. Yeah, you're right. Don't put a
cannot do that
4.5
for
into
when
the
I
LAD,
left
will
it.
be a trouble.
Yeah.
Got perforation.
Yeah. Okay.
Get a 408.
Hold on. Wait. Ready? Let's take a picture to make sure diag is okay. Diag is a trouble. Let's go. Beautiful.
All right. So far, so good.
Only question post dilation, what it will do. Let's see. With the left main, we definitely will do 4-5, but let us do the LAD first, optimization.
Yeah.
Then we go
but
to
things are shaping up better. Very good.
Yeah.
4-0. Yeah, let's
You
open.
can ask how many people would wire the diagonal.
Yeah, so question comes is that at the time of the stent deployment, I think maybe not now, but at that time, although still there is a pinch of the diagonal, let's ask our panelists and Markley that how many will protect the diagonal before stenting? Now, most will say leave it, but would you have done the...
I would protect it.
Okay. Nagendra, good. And Markley, what do you think?
No, I won't do it. I think I'll go directly.
Okay.
Because if needed, we can cross across.
Yeah, so there is a risk of wire getting trapped in this calcified lesion when we are using a long stent before the diagonal.
I
So
totally
there's
agree, Dr.
Okay.
Yes.
1680. You got it down. Now.
Yeah, we have to.
Yeah, here, right
area.
there, right here. Okay,
this
good,
area and
good,
distal
good,
left
good.
main also we need to go up.
Now get the 4-5 for the distal left main.
No, even this one first.
Is eccentric? Let's okay. Don't, yeah.
20 atmosphere only. Yeah, good. Nicely expanded.
Down.
Yeah. Open little left main also because left main still has not expanded yet. You saw it earlier. Good.
Go. Now, before this post dilation, if someone says you should take the side branch wire, that's okay too.
Means take the side branch wire out. Yeah,
no,
of course.
In the circumflex. Yeah.
Oh, circumflex wire. Yeah,
circumflex wire.
Yeah. No, but that's the time it's going to close, if at all, when you're post dilating. So you're right. Many times people will do, and we do sometimes also, that take the circ wire out now, recross it, and then go to high pressure.
Yeah.
So anyway, let's take the picture now.
Oh, perforation.
Dr. Kiri.
Perf. Remember, I was so concerned. 100%. I was not happy about going 4-0 high pressure.
Go to caudal then.
Yeah.
We get a long balloon, 3.5, 20 balloon we have, or 3 or 20. There's a little extravagation. Take the circ wire out.
I was not happy about that.
3.5, 20 we have.
Okay, take a picture again.
Yeah. You want to go low mag or so? Okay. Yeah, there is a little bit there.
Big, mega. Get us a covered stent. 4-0.
Take the circ wire out. Yeah, so there, so same thing. This is the whole case of the calcific combination causing the perf and
the. Are you planning papyrus or the?
Yeah, papyrus. Papyrus, yeah. $4.20, yeah. Good. Good.
Yeah.
Okay. I think the 4-0 balloon was a little more aggressive, although we didn't go to high pressure on that one. Yeah. So now you want to see if it is closed. No, you have to make sure the circuit remained open. You have to go a little distal. It's still there. Yeah, not enough. Okay, let's get a 4-0 papyrus quickly.
No, but you have to figure out where the thing is.
No, diagonal will be covered with this one now.
No, give some dye now. Give some dye there.
Yeah.
I think it's covered there, no? Take a cine.
Left main should be good, but not the...
Oh, where is the dye coming from?
Yeah.
Not knowing where to cover.
No, but after. No, but once you go after the left main, the circ, and we just do. I'm deflating. Prepare this quickly. Now there is a new balloon now called ringer balloon. If you want to do 4-20.
Are they ready?
Yeah, ready. Yeah, they're ready. Yeah.
Echo. You stopped.
And at this time,
anticoagulation has been stopped.
you stop the anticoagulation. Patient is on Clopidogrel only. Is not on the higher agents, which cause more trouble. But PRU was very effective. It was 30 only. 90.
Since we don't know where is the perf coming from, we cannot put the cover stent not knowing where it is.
Let's bring it up and then you. I think Caudal will be the one to tell you.
Caudal shot was showing it is in the proximal part, not in left main.
Yes.
If it's left main, then we are in.
Just bring it nearby and then we. 1 second. Don't connect there.
Okay, ready?
Yeah. Just 1 second. 1 second. Let me get everything ready. Yeah. Circ should not be covered. Diagonal we know will not be the issue. You want to advance wire a little bit?
Go. Cine.
Yeah, it's there. It's in mid.
It's in LAD.
It's in the mid. Go.
Oh, okay. Some die.
Good. This is it. I'm going up.
Okay.
And we have 4 high pressure balloons.
Careful now. Don't get
14.
crazy. Down.
If blood pressure start going down a little bit, let me do one more. We have 4 balloon ready. Yeah. Give a little near to the patient, right?
I think you have to go off live. Off.
Yeah.
Remember if somebody.
Yeah, so far the blood pressure is just okay. Let's take a little picture and maybe we have to start our other discussion.
Yeah, it is.
Yep. We take another view. Looking good. Ready? Low mag, right? Further low mag. There's a little bit of fusion collected. Good. It has stopped.
Nice.
And all the diagonal is not there. That's the only sacrifice we have.
Yep.
EKG is good. And good.
The circ is also having slow flow.
Yeah.
Get the 4-5 to the left.
No, circ is okay. See that? I gave a slow injection. Circ is all right. This is the circ. Yeah. What do we need to do? To me, everything just that area dilate with the foro, the papyrus stent, so they're fully expanded. Although it looks good.
I would just do the left main 4-5. IVUS it quickly. We should not be going 4 anymore. High pressure balloon.
Then 4.5.
You could open it more. This is for a 4-5. Yeah, for the left main. We never did the left main.
Yeah. Hemodynamically, patient is reasonable. So far, all the pressure is a little bit of blunted.
So the question is how we could have avoided this. Remember, I had 3-5 ready.
Yeah.
That's what we should have used in the left main to LAD. 3-5 and then post dilate.
Yeah.
Sometimes using imaging and going with what the IVUS is telling you, EL to EL and all that, could give rise to this kind of
I think
catastrophe.
this was the case we learned. It should have been a 3.5, 48, 28 hour synergy. That created a little trouble.
Dr. Annapurna, I totally agree with you because IVUS tends to give you the oversizing.
Yeah.
And,
I always say, God-given eyes. Listen to the eyes that you talk. See. EYE IVUS is more important.
One side there was nodule, the other side was free.
Yeah, that's right.
The only question is, after we did. Okay, good. Okay, give the IVUS quickly. Go with 8mm speed, okay?
Yeah, okay. I change the speed.
I mean, yes, after you do a covered stent, ideally you need to post dilate, okay? But we don't want to do that. We don't know if the cutting balloon has actually created, even when the cutting balloon, we went high pressure, and did it do anything at that time? Because many times with IVUS, you don't see if there was deep cuts, adventitial injury. Yeah, someone was asking me a question.
Yeah, Markley, you have a question?
Quick IVUS.
Yeah, I was requesting, you are asking for the IVUS run of 8 millimeters per second. Rather than
Yeah.
that, can we make it
Good.
little slower so that we can see the covered
Okay,
stent?
can you
How
show
does
the
it
IVUS
look
on the screen?
No, I just need, I do
Okay,
not
start
want to
feedback.
keep any device inside the body. Anticoagulation has stopped. So
Expand
I'm
it.
saying
Nice
do it
area.
fast and come out.
Left main. Yeah.
Good.
Stent
Yeah,
looks
looks
great.
good.
Take everything
Yeah,
out.
stent
Yeah.
looks great.
Yeah, now we have to just deal with that diagonal occlusion
Yes,
causing a
that's
little bit
okay.
of ST elevation, but that's it.
No, we will get a stat echo right now if he needs anything done.
No, but I think the angiogram point of view, we are done. We have done the post dilatation of the proximal eye. Imaging has been done. No more perforation, right, on that area
No.
by the IVUS also.
He needs
Yeah, it's
a
all
drainage.
covered.
There definitely is some effusion. We may have to deal with it.
What did you say, Kiski?
Yeah, stent is all covered the dissection part.
And
Yeah,
left
and
main is okay?
Yeah, left main is okay. Well posed, well expanded,
Beautiful.
and no edge dissection.
Okay.
Do you see that covered stent is up to the ostium of the LAD?
This is the left main stent strut, and this is the bifurcation.
Yeah, right
Yeah,
there.
yeah. Ostium looks strut, like 2 millimeter after the ostium, then
Good.
like a continuous tissue. This is the covered stent. So I think the 2 millimeter inside the ostium.
And circ remain good now.
Yeah.
Only issue will be that based on the echo, if the effusion is small or causing any compromise, we might do a pericardiocentesis. But to me, hemodynamically is good. We'll leave it alone. They should continue to show the hemodynamic. If everything is okay, Markley, you can start the lectures, and I'll just join you in a few minutes.
To see the pressure.
Show the echo, please. Show the blood pressure. Why are we not showing? They always should be showing. Yeah. And he always had this chin stroke breathing with the, this is not a pulsar paradoxus. He already had that before also.
They're coming, echo?
Yeah. Okay. All right. With that note, little tough case, but end seems to be good. Only issue negative remain now is the diagonal. Patient will have a diagonal MI. Some people will go and try to open the diagonal MI and pierce the papyrus, but I don't think, knowing the diagonal is there, but the rest of things looks good. Good hemodynamic. I don't think we should get too crazy. Only two things. Second question will be that do the echo. If any question about the tamponade or some physiology, then do the pericardiocentesis. Otherwise, leave it. They usually resolve by itself. And no, any last word?
No, I just want to how we could avoid this kind of a situation. That many times, okay, we did this. This was the stenting.
Yeah.
Okay, we already know when we were doing cutting balloon, there was eccentric, right?
Cut.
It was not easy.
Yeah.
So after stenting, this is what we saw. If we said, okay, we wanted to post and then go back, right? If angiographically looks okay, that should we have just done the left main and done the LAD, probably was okay also. Because this is what probably killed it, is this post dilation.
So in hindsight, do you feel IVL would have caused less perforation than cutting balloon, or is it the same?
No, IVL we have seen. I mean, this is 360-degree calcium. So usually IVL cuts are okay. But when it is less than 360, we are talking about 2 quadrants, 3 quadrants. We have seen that it does cause deep cuts at the level of the calcium and the, the media. So we have seen deep cuts. We have seen what is called as deep cuts and contained perforation even with IVL. So what my thing is that go smaller size of the stent.
Yeah,
angiographically,
size was a bigger issue.
Yeah.
But Dr. Kenny, very well handled. In fact, to do it live with so much patience and with so much confidence, this was amazing to see for all of us and all the audience who are watching it. Because we never discuss complications like this, and it's very bad that it happened. But then excellent way to handle it and excellent things to learn from.
All right. Thank you very much. And you start the lecture. I'll join you in about 5 minutes. Go to my office. Thank you.